Hi, this is Rich Branson. Welcome to the Respiratory Care YouTube channel. This is an author interview. Today we're going to talk about a paper called Optimizing Respiratory Therapy Resources by De-Implementing Low-Value Care. The first author and our speaker today will be Kellianne Fleming. Kellianne is the Director of Pulmonary Service at Froedtert and the Medical College of Wisconsin. Kellianne, thanks for joining us this morning.
Thanks for having me. I'm excited to be here.
So my first question is, what was the genesis for this study? What was the reason that you pursued this?
Well, we are a 700-bed academic medical center, and we knew pre-COVID that we ran a lot of nebulizer treatments per month, about 10,000 per month. So it was already on our radar of something that we might need to address moving forward. But then with the onset of COVID, we were in between COVID surges. We didn't have enough regular staff. We had lost a lot to travelers, to travel assignments, had to bring in expensive travelers. And even with the travelers, we didn't have enough to cover all of our bases. So we couldn't control the pandemic. We couldn't control the RT market. There was no one out there to hire. So we really needed to control what was in our control, which is what we do within our four walls of the hospital. So we had to look within. So we started with that, looking back at our nebulizer treatments and essentially going to staff and saying, what can we do to lean up your work?
So essentially what you did was approach this from a standpoint of the AARC clinical practice guideline on airway clearance made recommendations, and you looked at it and said, well, we're not always meeting these. So what were the challenges that you ran into?
Oh, well, many challenges, right? There's a long culture of this is the way we do things here, and having to break through that, right? I think we all experience that, and getting the buy-in. So what we did essentially as our staff identified, we do a lot of hypertonic saline, we do a lot of mucomist. So we went to literature, pulled those guidelines, and then also we were able to use our electronic medical records, and identify just how many of those treatments we were doing per month, calculate that out into what the time in FTEs was. So then we now had evidence from AARC, clinical practice guidelines associated with our data, and putting those two together and taking it to our CMO at the time to look at what our value-based care was for those treatments, which was nothing, right? So starting there and being able to get the approval from that level was great. But then what we had to do was really boots on the ground. So once we said, move forward, this is a little bit ridiculous, right? We don't need to be using 6.7 FTEs to deliver non-evidence-based care. Our challenges weren't so much with the higher level executives and the medical executives, but more with the boots on the ground. So we as a leadership team went to every ICU and to every hospitalist meeting, and we showed them the data and the evidence and specified it to their units and said, this just is not a good use for a respiratory therapist's time. That was where our hardest buy-in was. And once we were able to say, here it is, we're moving forward, we went forward with it. A lot of concern around, our hypertonic was being used for trach plugging, right, was the big concern. So a lot of concern about what was going to happen in any ill effects to the patients, which we told them we would, be tracking safety events. We have other evidence-based bronchial hygiene therapies that we are happy to perform. And then to build that trust, really, to get them to believe that we will still be supporting their patients, but we'll be supporting them in tried and true evidence-based practice.
Yeah, so for me as the reader, there's compelling evidence. You put this in place and you were able to eliminate therapy that wasn't necessary, which allows you to put people to work doing things that are evidence-based. But it's also, I think, if you can just comment quickly, it's interesting that you provided the information to the physicians and that caused them to change their practice a little bit. But it wasn't until you empowered the therapists to DC these orders that were unnecessary that really made the change.
Yes, that was the game changer. And you can see it in the data. We teed them up and they took it and they ran those nebs right downhill. So essentially, the respiratory therapists initially, they were like, this is great. Thank goodness we don't have to run around and do these treatments, was their first inclination. And then second to that, they were a little leery, right? They were like, well, are we really going to be able to do this? But we sat down, the leadership team sat down with each and every respiratory therapist and armed them with a folder that had the policy that had been approved by the medical executive committee, had the AARC best practice guidelines, had an algorithm of how to DC those treatments, communicate with the physician, DC the treatments, and a bronchial hygiene algorithm in case that would be something that their patient would be able to benefit from. So really closing that gap in communication between the respiratory therapist and the ordering provider was key, and having those real-time discussions at the bedside when they would call to say, we're going to discontinue this, and then showing those, the policy and the guidelines to the physician in the moment was really eye-opening for them, for the providers.
The other thing I think is really important, and I had some physicians tell me, well, of course, if you let the respiratory therapist decide if they're going to do therapy or not, they're always going to choose not to do it. But there were no change in the amount of bronchodilators that were delivered, which were evidence-based. So this clearly was an evidence-based practice, not simply some decision by respiratory therapy not to do some of these treatments that were ordered.
Correct. Absolutely.
Do you have any advice if somebody wants to move in this direction in their own facility?
First, I would get the data. We have the evidence, we have the clinical practice guidelines. Go find your data. Get the number of treatments you're doing that are non-evidence-based, calculate it into FTEs, take that to your C-suite. We're all facing financial headwinds as healthcare organizations. And, the C-suite understands that we're doing non-evidence-based care is really just taken out of their bucket of money, right? We only have one bucket of money per patient. So the less we can pull out of there, the better. And then we're saving time on the back end. So it's a win-win for the organization and the respiratory therapy department, being able to use those FTEs and repurpose them and, just really improve the overall workday and workflow for the RTs has been really key.
Great. This is awesome work. Congratulations again. For people who are watching, this is our editor's choice for May, Optimizing Respiratory Therapy Resources by De-Implementing Low Value Care. Kellianne, thank you.
Thank you.